Hi, good evening, everyone. It's fantastic to be with you once again. The last time I was doing this was during COVID lockdown, so thank you so much for joining me today. So I want to share with you this case. It's actually a case which is I've just literally sent this out yesterday as a newsletter, showing Marissa and the treatment of Marissa. And the reason I really want to show this case this evening is because it was so hard, both technically and also managing this patient. Because the main message that I'm really wanting to get across tonight is that if the implants are in the wrong place, it makes everything so difficult. It makes making the dentures fit well, and it also, if the patient is and makes them difficult to fit, also makes them not great to look at. Plus, if we've got potentially a patient that's not easy to treat as well, on top of that, it's like a perfect storm of difficulty. And this is what I experienced with Marissa. So, how I'm going to work this at the study club is I'm going to show this case all the way through. I'm going to stick to 1 hour doing this. Um, I'm going to stop and pause for questions, and you can just pop questions into the chat box during the whole process. So I'm going to pause at little intervals, like after primary impressions, definitive impressions, and then I can then pick up on those and just answer a few of those. Um, if there are some internet glitches, please forgive me. That's just the nature of how it is at the moment. And then we'll end with a little call to action. So thanks very, very, very much for joining me. There's loads of people I know from all over the world, which is fantastic. And there's some of you I know I'll be seeing very, very soon next week, and someone from Canada on there. So it's going to be great. Thank you. Right, let's have a look at this. So now this case was super hard because these are the impression copings. These are impression copings on top of Marissa's implants there. And look how badly angled they are. This is what we achieved and with the end outcome. So I just want to talk through that. When I see a new patient, I prefer now, and since COVID, is to do a Zoom call with the patient because I love to see them over the computer here, and they can take their dentures out. They can show me what they look like and show me their teeth. I can get an idea of what is needed, and so in doing so, I can just give them a potential idea on costs. Some of the older patients, and Marissa's in that category where she's 86. She doesn't like using Zoom. She wanted a phone call. So I spoke to her. Now, she was referred, she's a local person, and she was referred by a local dentist to me. And the dentist sent me in this radiograph, and I looked at the radiograph and I thought, oh, flipping heck. Look at these. I bet these implants are all over the shop. And also, bone levels are not great with them too. They're Straumann's upper and lower, and they've got studs on the top, and we've got locator attachments on the bottom. So I picked up the phone to Marissa and did my telephone call. And she was really wanting, well, she told me basically she'd had this upper denture and these implants done in around about the early 2000s, these upper implants and an overdenture. And she'd had a number of overdentures made for her since then. And she'd had the lower one done, these two lower ones done in 2010, and a lower overdenture. She wanted a more natural looking denture, and also she was just fed up with having to go backwards and forwards to have them, in inverted commas, tightened. She's 86, super fit, really active, involved in loads of stuff, but also a talker. She just wouldn't stop talking and talking and talking and talking, tell me about her whole life, everything. And I couldn't really get my point across or get any sort of, I had to wait and wait and wait. And then as soon as I mentioned about something, she'd then talk and talk and talk and talk. So immediately I just knew that she wasn't a great listener. But over that conversation that we had, I said to her, look, Marissa, I think I'm gonna be able to help you with this. And the treatment costs may range between 12 and £16,000. So that's what and she said, okay, that's a lot, but I'm prepared to come in. So she came in, and this is her with the dentures in place. The dentures are not too bad. She wanted them to look whiter, lighter. That was one of her wishes. But aesthetically not too bad, but too full in this lip here. I think this is really super important here. When I see this bulkiness just underneath the base of the upper lip, that means the denture is just too bulky at the front there. And I want it more thin and coming out like that to get a better lip support for the patient. You can see here, Marissa's, it's just a little bit too bulky, really, in those areas. I like to take loads of photos. I love taking photos because it just enables me to diagnose what is going on. This is a upper denture that she's had. She's had this in for probably about 10 years. And what I see is when patients have been wearing an implant supported overdenture, they're often really worn, flat, because they can really chew on these things. That's a lower denture, again, worn pretty flat, not nicely border molded. It just could do with being improved in terms of extensions. You can just see that there. When I looked in the mouth on these implants, I could tap them all. They're all integrated, although definitely on borrowed time, but borrowed time in an 86-year-old patient. We've got a balance there. How long is they going to last? I'm not massively concerned, to be honest, even if we lost one or two. The new dentures, we could make them fit really nicely and they would still work really well. But this is the issue really here, is the angulation. And this is the sort of through message I'm really wanting to talk about tonight, is that if the implants aren't placed nice and parallel, then it makes everything so much more difficult. Everything wears much more. The fit is more difficult to get working. And also massively important, the aesthetics, because the implants get in the way of where I want to put the teeth, and it just makes the whole thing super hard. You can see how that side of this locator is just worn away. You can see also the redness of the gingiva. She's got some denture stomatitis. I find that is quite straightforward to sort out with some oral Dactarin. Just some gel just placed in the denture can help with that. So here we go. That's it there. This is the upper denture. She's using quite a bit of fix in this. It's not fitting very well. And these clicks attachments, these metal attachments that go on the balls, I've found that these are not as good in the long term for maintenance compared to locators. So in these cases, I just automatically go with locators. In the lower jaw, the dentist that had previously treated her had actually done locator attachments for the patient. But really, what I really think is so important about the whole thing is that I think being really good at dentures, being really good at tooth placement, getting the teeth in just the right place for complete dentures is like a key skill that we need if we're going to be doing implants, because positioning the teeth first and knowing exactly where they're going to go is a great diagnostic tool for positioning where the implants are going to go. And the implants can be planned accordingly, exactly. And then drilling guides, these really precise drilling guides can be made so that implants can be just put in just the right place. Even if CT scans are not used, and they are used in Britain all the time now, but I know worldwide they may not be used. Really good surgical guides are so important to help position the implants exactly where we want them to be so that they can sit in the prosthetic envelope. This is a different patient. This is Lynn, and you can see that her implants have been placed in a much more favorable position parallel, which enables the making of the denture with with the teeth in the right place, with no silly bumps and lumps that can get in the way when implants are just badly positioned. And the overall denture can look great. And we can just put the teeth back where they were naturally, just like for Lynn here. And, we can really mimic the smile. And I'm not inhibited in putting the teeth in the right place if the implants are in the right place. So I'm beginning with the end in mind. That's like super, super important. That's really, really good. So let's go ahead. Let's crack on with visit one. Now, so what I chose to do for Marissa was to make some new upper and lower complete dentures, change out the attachments as well. So put locator attachments on that are really as low as possible to give Rowan, my technician, as much space as possible. I think she paid around about between 12 and 13,000 British pounds for this. And the dentures were going to be metal reinforced. So let's go ahead. So I'm using my small transform tray here. And what I do is I just select the right size of tray by looking at the size of the denture. And the next thing I do is I want to do the impression into two bits. So I load up this syringe here with alginoplast. That's in a big syringe, 35 milliliter. And then I can inject that into the sulcus and also a little bit up into the vault of the palate. I also load up my other tray here with thick alginate. Take that to the mouth, rotate it, and then push that in. Push it up at the back first, and then up at the front second. And because I've preloaded, this is really important, I preloaded the sulcus, I capture a lovely sulcus impression, because capturing the sulcus is so important with these sorts of things, I find. In removable pros, super, super important. So this is directly over those studs, just over the mouth there. You can see what I'm wanting is the full depth of the sulcus all the way around, there, just like that. And it's a really great way of doing it. It's just this two-step technique. Love it. And it's super predictable. Can you see that torus there as well? That's interesting, isn't it? These sorts of things we're just looking at. Super, super important. Right, in the lower, what I love doing is using, for complete dentures that are sitting over, that sit over implants, I just do it exactly like I would do for a complete denture, just like the Dr. Arbe technique, using the frame cutback tray here, like that. There. And this is a medium tray that I use. 70% of my patients are medium size. So that, and I select that by just checking that in the mouth. And if this edge here goes back to where the distal of the retromolar pad is, that's the right size. I want the retromolar pad to just be sitting here. And it's a two-part technique. Again, fill up that syringe with alginoplast. So Claire, my dental nurse, loads that. I load this. I always glaze it with running water, reshape it, and then I take that to the mouth and I squirt it right into the retromylohyoid area, all the way round, lingually, all the way round, up and over the retromolar pad, and into the labial sulcus, all the way round. And then place this over the top. And that's what I get. which is full depth of the sulcus all the way round, retromolar pads. I haven't changed the abutments yet. That's the impression. So I've captured everything. Might just be a little bit short here, but I didn't do it again. It's going to be fine. I'm quite happy with that in terms of producing my special tray all the way around. So that's my retromolar pad, full depth of the sulcus, and that's there, nicely done. And I find it really consistent, this method, using that. So I find it that I very, very rarely have to redo my impressions using these two-step techniques. In fact, I can only think of 2 times in the past 10 years in a lower where I've had to redo it more than once, because it's such a predictable, lovely technique to do. So I'm now going to just have a quick look in the chat here and just check out any questions. So Jessica Jeffries has said, Finn, do I use tray adhesive? No, I don't, Jessica, because I like to reuse particularly the lower, which I think is really important. I can't get hold of the frame cutback tray anymore. These have been discontinued, certainly in Britain. So what I do is I don't use adhesive on these. There's enough alginate to wrap around so that it just doesn't peel off. It doesn't need adhesive. And then Rowan just cleans it up. We disinfect it, and then we can reuse it again. I think also the other beauty about this now is that we can also, you can still order these off eBay in Britain, this shape here, but also if it's just going to be discontinued, then I think printing them is fantastic. You just scan and print. Right. So let's have a little look at it. Mohammed Khan, what are these trays called? Frame cutback tray, FCB tray. That's what they are. And they're made by Morita, the Japanese firm. What's the reason for the running water? By Michelle. So that's a good question. This reduces air bubbles by 50% just by glazing it with running water on the fingers and rubbing it over. It's fantastic. Antoinette, where do we buy your injectable arginoplast? That, Antoinette, lovely to hear from you. That is available from Kulza. It's a Kulza product. So you can just get that from Henry Schein. What do you say when you say two-stage, do you do blue alginate in first, then wash on top? No. Nabila Bhatti, no, it isn't. It's 2 steps to it. So these are all runny at the same time. That gets injected in, and then this goes over the top. So they set together. It's just in one go. What is your experience of using periphery wax to board a mold? So Nolan Nido, very bad. I don't like it. Why do you prefer alginate for primary impressions? Because it's just a lovely hydrophilic material. It's less compressive than compound. I used to use compound. It's less compressive, hydrophilic, and it loves moisture. And it is really super accurate. Do you have an alginate mixing machine that I recommend? Yes, I do. I've got a Zermatt alginate mixing machine which spins round like that, and we've got that from Henry Schein too. So that's super. Thank you very much for those questions. Let's carry on now to the next step. Just one sec. Here we go. Visit 2 is do my working impressions, and also I do a primary jaw registration. So at this visit, what I've done is I've ordered some locator attachments. So I've pre-ordered these, and these are, so I've got 8 1 millimeter, so the lowest possible locator attachments that go onto these tissue level implants. So what I do is I undo everything. So I use my locator attachment tool to take off the lower abutments. And by the way, these were 2 millimeter high ones, and I wanted to get 1 millimeter high ones on there. And then these are click studs. So the issue when I'm doing working with implants is it's just a faff, because you've got to have loads of different drivers for these things. I do find it a bit of a pain, actually. So these are the abutments removed from there, and this is the upper with the abutments removed, lower abutments removed. I've got my new locator abutments, which then fitted. So now what I have to do each stage, every visit from now on, though, I've got to do what I need to do with these on, and then take them off, put the old abutments back on, so she can go home with her dentures in and wear them okay. So, but you can see we've got less, this isn't sticking up quite as high. These don't stick out as far as the studs and don't quite get in the way. Now, some people say, Finn, why don't you use angled Novalock? These are just designed for this sort of thing. Well, they are designed for poorly angled implants, but the minimal height of this sort of thing that will fit onto a tissue level implant is 2 millimeters. So the locator abutment is half the height of this. And there's also what Rowan calls an elbow, where it actually curves and bends round. And this just means that there's even more space is taken up in the denture with these than with the locator, the 1 millimeter locators. So I'm going to next do my working impression, and I do a spaced tray at the top here, custom tray, and Rowan puts plenty of space over where the abutments are going to be. I'm going to do a pickup impression. And so Rowan makes this custom tray with 3 millimeter wax spacing. So that's 2 layers of sheet wax, 1.5 millimeter each. And I want it short of the sulcus depth all the way around. And I want it right over the vibrating line at the back there too. I'm going to talk about the extension later, about where we position the back of the denture, but I like it to be a full extension to start off with, for sure, to take my impression. So this is my special tray. Notice Rowan keeps that handle out of the way of the lip, so it's not going to get in the way of the lip. So that's my upper tray. And I'm going to use Impri gum here, by the way, like that. The lower tray, I make that close fitting, and I make it designed just like the Dr. Arbe system of fully over the retromolar pad, avoiding the Samaya sinew, keeping it short of the buccal area here, the edge of the mandible, 2 millimeters short, free of frenum all the way around, and also just dropping it in on this side into that retromylohyoid space. If you want to learn more about that, just look at my complete denture construction manual. The whole instructions are in that to exactly design special tray, because I want the denture to be really well supported. And also, if she loses these implants, she loses that implant, she's still got that one to work with, and the denture will still be nice and stable. So that's the look of it here, like that. There. So nice stub handle. It's reinforced on the top by a little, it's like a T-shape section there. I also get these primary jaw registration rims made as well, because I do a primary jaw registration so that I can then do a Gothic arch tracer to record the bite beautifully at visit 3. Hold that thought about that. I'll show you that just in a minute. So we've got our new locator abutments fitted like that. I then fit on the locator impression pickups. And what I have to do here is to make sure that they fit really well. And I push them on so they're not going to move and jump off there. So we're going to record this lovely and accurately, because in these positions, now I'm thinking about the end product at the moment. I'm thinking about when I come to fit the denture, if I've got implants angled like this and I cold cure my attachments in, I'm in big danger, massive danger of getting it stuck in the patient's mouth. And I do not want to do that at all. So in these cases, I always get Rowan to process these in the lab. Super important. So this impression is critical. The most important stage of the whole thing. Got to make sure they're properly on. But look at this. Just look at this photo here. How implants just get in the way of putting the teeth in the right place. So annoying. And I was talking to Rowan, my technician, today about this. And we get, I'd say, 90% of patients that are referred to me with existing implants, 90%, some of the implants are in totally the wrong place. And it messes up the restoration massively. And if we've got a challenging patient to treat, it's really super hard. So anyway, for the upper here, what I do is I use green stick, and I put green stick right onto the center of the pallet there, and green stick right onto the fitting surface of the tray at the back there. So I soften that up in my water, which is just in the sink in a kidney dish, soften it up in hot water, take it to the mouth, push it up, it seats just onto the ridge there, make sure it's sitting square in the mouth, and then I take it out, and then I add green stick buccally here, buccally there, and I make sure I've puckered it out like that, there and there. And then I soften it in the warm water back in, take it to the mouth, and I put it in the patient's mouth, press it up, and then I mold the cheeks, both right and left, and ask the patient to waggle the jaw. And it makes it go like that. So I'll go, look at that, how these have narrowed there. So go there to there, look at that. It's amazing. And then what I do is I put my Imprigum adhesive on here and dry it, and then load this up with Imprigum like that. I take this to the mouth, pop it in, push it up firmly into the mouth, and then I go through all my border molding process. And the border molding process is pulling the cheeks, waggle the jaw side to side, open wide, and also suck my finger. And then there's two other things that I'm doing more and more, which I think is super important, is to pretend to blow out candles. Pretend it's your birthday, like that, and have a pretend yawn, because those movements are all going to border mold that edge. So this is the impression when it came out. So when I took it out, the impression caps, the black caps, stayed in on these two implants, but the ones that were really pitched, the impression housing just stayed on the implants, abutment, but the impression pickup, the part that was shaped like a wine goblet, stayed in the impression nicely. So super important. It's a beautiful impression there. So I push those back in like that. These are the lowers. You can see how that's pitched there. Let's do the lower impression next. So I'm going to put that over like this. The pickups on properly. Start border molding using this technique. So is I put my green stick on the edge of the tray, not on the fitting surface, on the outside of the tray, so on the side of the tray. Put it in and get the patient to go ee ooh like that. Really go for it. Ee ooh. I want them to move their lips so that it really narrows it beautifully in these areas and molds right up round there like that. So we've got lovely polished surfaces. Next, what I do is I get a thinner section of earthworm all the way on the inside here. And then I push that in and down and get them to lick their upper lip side to side like a windscreen wiper. Push with the tongue against that lower front strut and have a powerful swallow. And then you can see the change. Can you see the change in that? Like that. So that to that, border molded by the functional depth and movement of the sulcus. So, and now we're ready to do the working impression. So we can load this up, but can you see how I've beautifully started to develop these polished surfaces? This is what I love seeing. Prosthodontists love polished surfaces on dentures because they really do help hold the denture down too. Super important. Love it. I put my adhesive on, dead important because this can really peel off. Load that up with Imprigum and then take that to the mouth. And I repeat all those 5 movements. So it's E, ooh, push that tongue right out this time, side to side, windscreen wiper, push the tongue against the struts here, good, powerful swallow. And this is the working impression that we've got here. So I know a lot of you are going to be like, oh, flipping heck, we've got the tray poking through. What a disaster. Well, do you know what? I don't find it a problem at all. And if when I'm coming to fit the denture and it's a little bit sore in these areas, I can just ease it off just with some light bodied silicone to check those areas and just adjust it. But truly, it really isn't a problem at all. If there's a flabby ridge, if there's a movable ridge though, that's something going on, then what I would do is I would ask Rowan to put tin foil, a spacer, directly over that ridge area. So that's the impression. You see beautiful polished surfaces there. That's it there. So I'm not worried at all about this tray showing through in these areas at all, but I will double check it's not going to hurt when I come to fit it. So that's why taking these photos I think is really important. Okay, let's have a look at your chat now and answer some questions. So, do you use Vaseline to help with the green stick? Yes, I do, Jessica. Great question, because if I don't, it really sticks to my fingers. So I do put a little bit onto my fingers and then I can pick it up directly out of the water bath and manipulate it just like plasticine. Octavian, I love your name. Implantologists don't think about the end product, just where the bone is. Absolutely, totally agree with you. And that's why, if you do work with an implantologist, watch them like a hawk. Go and see them placing the implants. Take that drilling guide, hold their hand, and all of that. So important. Do you trim the border or border molding before final impression? Sam Sudin, no, I don't trim the border of my of the impression, but sometimes I do need to trim the edge of the tray if it's overextended. If it's pushing into the sulcus, I'll trim it back before I do my border molding impressions. So hopefully that's answered your question. Nabila, how come you don't add green stick to the fitting surface of the lower tray? Because it's a close fitting tray that I'm using in this circumstance, and normally I'm using zinc oxide there. But Nabila, I don't, in fact, I think probably looking at this, is I think it might be better if I started using a little bit just in maybe 3 locations, just on the fitting surface, just to jack it up a bit, and then I'm not getting my tray pushed through there. So that's really good. I like it. So would you ever use Blue Sky software for implant supported dentures? Um, so not, no, I wouldn't. I don't think so, because well, actually, Georgios, I'm not sure what you mean by that. Um, whether it's making the denture itself or planning it. I think planning the denture, planning the implant placements and scanning a denture, definitely. So that would be work beautifully, using that too. Yes, planning the implants, absolutely. So I think that's a really great idea, and how it should be done using some form of scanning software like Simplant or your Blue Sky software too. Thank you. Right, so next what I want to do is just move on to the next part here. So this is, we're still at visit 2, and I do a quick jaw registration with these 2 wax blocks here. And what I'm doing here, and this is purely to help me produce a Gothic arch tracer for visit 3. It's not, and I repeat, this is not for prescribing where the teeth are going to go. It's not a tooth prescription for Rowan. So I put this in quickly, trim it up to get the patient at roughly the correct vertical dimension here. So this is Marissa with this in place here. So that's trimmed up like that. But I'm not using it. This is not for positioning the teeth. I'll do that at visit 3. I'm very, very particular, and I know a lot of prosthodontists and people that want to make really great quality dentures, dentists that make really great quality dentures, denturists, CDTs. We love using Gothic arch tracer to find centric relation, and that's what I do for all of my complete denture cases. So this really helps me do that. So once I'm happy I've got the right vertical, and I use the John Coyce method of getting the right vertical, which is if the patient looks right, they are right. And then I squirt my Futard D in like that. You can see I've not even put a centre line on it. It doesn't matter at this point. This is just purely to help Rowan mount these 2 working casts there. So this is what the lab works like at the end of the visit too. And I do like to just myself get the analogues, the locator analogues, and literally push them into the impression just to make sure everything's fitting nicely. This will then help. This here is my primary jaw edge, help me mount that too. So these are the impressions. I've got this border molding. They just look nice. Super happy with those. So these are my working casts. And you can see, look at the angles of these implants. That is just a nightmare. I hate it. It just means that the denture is just not going to fit particularly well on it. A real pain. There. That's the lower one there, with that one that's really just tilted, cockeyed. So what Rowan does here, he pours those working impressions, and then he makes the primary jaw registration fit by trimming away this border here to allow those wax blocks to fit together. And then he can do this primary jaw reg mounting. And then from that, here, like that, you can then make a Gothic arch tracer, a central bearing tracing apparatus to fit onto that. So that will mean that when I try this in the mouth for visit 3, they'll fit nice and parallel, and this plate, the pin's going to run nicely for me to find central relation. They're going to be nice and parallel. And so he's not going to set the teeth up using that. It's purely to mount that at the same vertical that we've got. That's 0 there. That's 0 there. So let's fast forward to visit 3 now, to the registration stage. So I'm going to use my wax rims. So I've got 2 lots of bits here. I've got wax rim here. I've got a lower wax rim. We call it a Manchester rim here in Britain because it's got 2 little blocks on, and it was invented in Manchester. And in the upper here, we've got a plate and a pin. And so this is our Gothic arch tracer. So I'll just take you through these steps here. So I've got my wax rim and pivot there, like that. A detail that's really important, is Rowan doesn't extend this base plate over the retromolar pad in this instance. So, but he will finish the denture like that, but not at this point, because sometimes it can just get in the way of the bite. So Rowan makes the upper wax rim here massive, both that way and that way. So much bigger than it needs to be. So I can then just trim it back. So it's a minimum of 13 millimeters forward of the incisal papilla, and it's at least 30 millimeters high there. So 13 there, 13 forward. And I can just put that straight into the mouth and go for it. He strengthened that with shellac, like that. This is the lower. This has got a lower base plate, and we've got our Manchester blocks there. So I trim that up in the mouth like that together, and I trim it with the patient sitting upright, and both me and Claire look at the patient, and we go through this recipe in order. So we carve and it's the upper rim here is the first 5 bits to start off with, and then the sixth stage I put the lower block in and do the OVD. So I'll just talk you through it. So number 1, I want to get the lip support right. So put that in. It's usually massive, like that. I take it out and carve it back, and then put it, and I trim that until I'm totally happy with how that looks there. I then trim the incisal plane parallel to the interpupillary line. I use these photos here like this. So this is a picture of Marissa as a young woman, and you can see that her incisal plane is parallel to the interpupillary line. And this also gives me an idea of lip fullness too. These pictures are invaluable. I get the patient to really look for them. So I want to carve the incisal plane parallel to the interpupillary line. I then trim the occlusal plane parallel to the alar tragus there, and then trim the buccal corridors using all looking at these pictures. But also I've got to be mindful of where the implants are too, and then do the center line as well. And then once I'm happy I've done that, I do the OVD and get the OVD correct. And I just look at the patient and think, if they look right, they are right. I love using this Fox's bite plane for doing the incisal plane parallel here, and also getting the alar tragus correct. This is a great little tool for doing that. I've got my center line on there. These are the trimmed rims. These are them in the mouth. Here, the trimmed rims. It's still a bit full, but I've just got to get it over that. I've got to get it over that flipping implant at the top there. This is trimmed parallel to alar tragus, the front there, like that. And these are the photos I give to Rowan. You know, these go to Rowan like that. This looks like, I can't see the side of the ear there, but it looks like it probably is parallel with the alar tragus. Maybe I've over trimmed it just a little bit there, and it just needs to come down a touch there. And this is where the beauty, me taking these photos, so important, because then Rowan can have a look at it and then work through it like that there. So yeah, just looks like I might have just over trimmed it a little bit, but there's a little check in the system because Rowan gets this on his iPad. So there we go. So these go through to Rowan. He gets all these pictures. It's really nice seeing these sorts of things. She brought plenty in, gives a good idea, but there's no way I was going to be able to achieve that sort of aesthetic there because the implants are in the wrong place. And then next what I do is I do a bite fork on the trimmed upper wax rim. I love doing a face bow. You know, there's loads of detractors from using face bows. People saying you just don't need them. It's bloody blah. We love it because it means that we can mount it on the articulator, just like Rowan's got her head on the bench looking at him, and then he can arrange the teeth accordingly. So, and it's just a 5-minute job. It's dead easy. Just pop it on. I use the Denture system. It doesn't matter what system you used. It wouldn't, you know, we've always had the Denture system in the practice for 17 years and we've got 5 articulators. So that's what I use. So that then means that the upper cast can be mounted beautifully there. So that's all done. And then what I do is, these are the primary jaw registration. Sorry, this is the mounted model. I've got a mounted cast here, which has been mounted using the primary jaw registration. I put my new trimmed rim and lower block on, and this is at the new vertical. This is important. This is the new vertical dimension. And so I set the pin to that vertical, and then I can then set this screw that goes up and down to the vertical of what we've wanted in this really, this is exactly where we want the teeth to go. So I set that to the right vertical, and then I could take this to the mouth. And I love doing this. This is so accurate, superb. So we've got a flat base plate lower pin here that fits onto the working casts. That's the upper with the pin. And you can see what we do is, it's quite nice here. Rowan's used the impression pickups on the Gothic arch so that they actually can fit and clip onto the fixtures, and it just gives me an indication of how well the dentures are going to fit when I come to finish them. So it's quite nice. So once I've checked that in the mouth and made sure it's fitting nicely, I can then warm this up here, and then I use a China graph pencil and pencil that in, take this to the mouth, and then the only point of contact is here. And the patient can go forwards and back, side to side, forwards and back, side to side, and go anywhere and make a mark on it. And they produce these lovely arrowheads here. And this point here, right at the tip of the arrow, is precisely centric relation. Sometimes we call it retruded contact position in Britain. So what I do is I put a disc over that little hole, put some melted wax on, glue it on, and then fit it back into the mouth. So this little plastic disc comes with the kit. I just glue that on with some wax, put that back in the mouth, get the patient to go into the hole. Now, to lock it all together, I need to squirt in between all this area here, FUTRD bite registration material. So that goes in between them, just like that. So Claire's actually got some retractors in the mouth whilst I'm doing this. And then I just take that out, take out the retractor, and let it set, just like this. So that's setting here in Marissa's mouth. So I send Rowan a load of info back here to once I finish lab end of visit 3. This appointment I use, it takes me 1.5 hours to do this jaw registration stage. If I wasn't using the Gothic arch and I fix this together just using the pivot there conventionally, I would spend 1 hour with the patient, not 1.5 for this visit. So then Rowan uses that to mount everything up. He's got everything he needs there. I also do a shade taking, and Marissa wanted really white teeth. I tend to like a shade, but she wanted a bleach shade, and that's fine. I'm seeing more and more people wanting bleach shades. That's fine, absolutely. Right, I'm gonna now have a look at Q&A again so quickly. Finn, please explain why you please would you explain why the pin was initially set as 0 on the articulator, but then when you're working to the 2mm of the Gothic arch setup, I can't quite follow. So Jessica, I'm going to go back. So this is my primary jaw registration here. So the primary jaw registration is set at 0 there. And so Rowan mounts these models to start off with like that. Once I go, this is the primary jaw edge. So this is my rough, it's a very rough jaw edge at a vertical that I think looks okay at that point. Now, when I come to actually do the actual next visit, which is visit 3 here, and this is really carefully trimmed, carefully looked at, just using the photos, getting the vertical just as carefully as possible. This, in Marissa's case, I jacked her open by 2mm compared to how she was with her primary jaw registration. So when I put it back onto the articulator here, my really accurate trimmed rims was 2mm greater, or even 3mm looking on there, isn't it? 3mm jacked open compared to my primary jaw edge. But I know that this looks good in the mouth, and that's where I want to set the teeth up to. So the Gothic arch tracer, rather than it being set at 0, we've set it at 3mm instead. And that means that the accuracy of finding CR and the accuracy of that bite is better because I'm doing that at the vertical I'm going to restore the patient to. So that's great. Lovely. Good. Right, let's go. Let's crack on. Lovely. Okie dokes. Move forward to the denture try-in. So here we are. So what Rowan does now is, from doing the jaw registration, he gets this photograph and lots of other photos too, because I send as many as he needs. And then he arranges the teeth as closely as possible according to her smile. She wanted her natural smile back. So this is what Rowan's created with the super white teeth. But this, can you see how that's stepped forward? And this arrangement there. So he sets up the teeth over those implants in the best way he possibly can. That tooth's probably sticking out slightly exaggerated because of that tooth, that implant just there. So this is a wax try-in. Should we go to for the patient like that? Denture wax try-in. I don't have it attached to the implants. I just sit it over those locators, and then I just check it in the mouth. And you know what? With doing the Gothic arch tracer, this is like super important. Is I find that my bite's really, really close. It's just bang on with this here. She's not fully closed on that photo here, but I just love it because the bite's so beautifully down together. Also, the other thing, we're not bothered about cross bites. We're not bothered about edge to edge positions. I just want to put the teeth back as close as I can to nature. So that's her with the mini. It's makes me laugh, that photo, because it's so bright. It's so wrong. But that's just what she wanted, so it's fine. I just go with it. It's just not a problem. And what I always do here is a video of the patient so that they can have a good look at them, make sure they're totally happy with the aesthetics there. You can see that I don't lip fullness, don't like it, but we've just got to, just because of where the implants are, really. That's her smiling. She really liked this, actually. She loved it. So we went ahead. She really loved it. And she sat down with Claire. She said, yeah, I want to go for it. Yes, please. So that's what we did. So processing the dentures, just a little bit of technicality here, which I think is dead important, is metal strengtheners. Now, for whenever I've got implant supported overdentures, Rowan and I, we use chrome cobalt. It's Knit is the stuff we use, a Bigo product. And Chris Hesketh in Chorley does this for us. It's terrific metalwork. And then it's painted with opaque. So we've got metal that just sits over all of the implants. And this stops things from breaking, because I do find that patients break these dentures. Anything with implants increases the wear, increases snapping, chipping, cracking, snapping of teeth off, breaking of things. And patients, if they're paying a lot of money, I've found get really cross, really cross if things fail. So Rowan makes sure that the metalwork can fit within the try-in. This is why we only do the metal base once the try-in's been verified and the patient is happy with that try-in there. So super important, this there, like that. So the whole dentures get finished. So these are back to Marissa. So we've got the working cast there, and these are the finished dentures there. I want to just show you how much space we had to work with just by superimposing some locator hats there, and then and how bulky we've just got to make this anterior section there. Just gets in the way of exactly where we want to put the teeth. Marissa had some other absolute musts. She said, I don't want any texture on the denture. I just want it polished, absolutely ultra smooth. So that's why there's no texture, no little, yeah, sort of like orange peel, that lovely texture you get from natural gingiva. We just got none of that on these. Horrible, don't like them. But look at how wonky these implants are. And then Rowan's got to fit everything around. You just go back there. It's all like bulky over these areas like that. So that's the denture, upper denture finished with the metal insert inside it. I tend to favour these metal inserts inside and having acrylic on the outside, because the speech I find is better, because it's a lovely smooth surface there for these patients. So I'm not favouring as much an exposed metal edge, but it's only just one of my patients, a couple of years ago, just had a speech issue with the metal junction here. But it's like once bitten, twice shy scenario. So I don't think it's a major deal. So this is the denture there. Finished. She wanted it absolutely polished to high heaven. Like that. This is the lower. You can see I've extended it beautifully, like Dr. Arbe, right the way up, fully, like a complete lower. Now, please, if you just have a look at this, she wanted the gum work right up to the edge of these teeth like that. She specifically said that. like her old denture, because normally we would expose all of these teeth. So it actually feels like teeth to the tongue. So that's the denture there. Okay, so it's ready to go. Let's get it fitted. She wanted all that plastic up to the edge. That's the inside. Here's with the process caps on. And I take the process caps out when I come to fit the denture. I just want to make sure it's fitting nicely, it's comfortable. Same for the lower, get the process caps out and then check them. So in terms of weight, the old denture is 14 grams. This was an all acrylic denture, 14 grams. The new denture is 24 grams. You know, it's 10 grams heavier, quite a bit heavier, noticeably, but just much stronger, less likely to snap. The lower was 16 grams, the old one, and you can see the extension differences here. And it's important to just chat through with this with the patient before the dentures are finished. So let's get them fitted. So with these wonky implants with the locators, if I've got wonky implants, I only go for the ones without the male attachment. That's the male section in this one at the top there. I do them without that male section in there because the wonkiness just makes them so difficult to fit. So this appointment, I have to tell you, I spent 1.5 hours fitting these dentures, and it was so stressful because they hurt when I was trying them in. Because of the angles of the implants, I've got to try and get them to fit, get everything to sit nicely over the top. And so the end outcome was that at the finish, I only used the 2 front implants. I didn't actually put anything in these back implants at all. I did try greys. Now the grey attachment has 0 retention. I tried a grey in those there and there, but Marissa just couldn't take it out. She just couldn't get the thing out. And this is the issue with wonky implants. It's so difficult to make the denture fit really nicely. Unlike Lynn, who I showed you just before, if they're parallel, they can just out, in, out nicely. Big deal. So that's how she is now. And also, when I fitted it, she hated this extension here, which I test. I test this at the jaw registration stage, and she was absolutely fine with it. But she really, we call it, she really kicked off. She really said, "I do not want like that," really angry. So I trimmed that back like that. It's still pretty much a full palate, so we've still retained that strength, but we've kept it away from that area and in front of the torus. In the lower, I've used orange attachments. In fact, there's an orange attachment and a red attachment there on those two, like that. So that was her at the fit stage. Super white, amazing. And there, so I got it fitting and comfortable, and off she went. So she went away for 1 week. Now, bearing in mind, she's got her new abutments on now, so her old dentures are redundant. She can't use them. She had to wear these. She came in like this, and she was like really angry. At appointment one, like really angry. She didn't like the look of the front ones, like a rabbit. Even though we've done the video, she's seen the video, she's verified it, she's seen a photo, she's totally happy with it, trying. And when I say to her, look, you did say you did like them, and she was just not listening at all. She was just not interested. And she wanted them shortening on the retromolar pads on the lower. And also the upper and lower back teeth were too far sticking out as well. So, and she wanted them adjusting. So I was really worried about this, and I got Rowan in, and we sat down with him. We just talked it through, and I was like, just really sort of thinking, gosh, have I made a big mistake taking this patient on? You know, it was so bad, this particular appointment. But anyway, we set to the denture and I adjusted it here. So I took it from that to that. Can you see the difference in that tooth there? We've sanded it right down. We've really gone to town and ground down and polished these back teeth there too, taking these edges off. She wanted them flatter. She didn't want these pointy bits. There, can you see? And ground right into that tooth. You can see here, totally taking it away. Totally ground them, change the shape. So you can see how I've already, brought that forward and trimmed away these teeth there at the top there, totally changed their shapes. Cut that right back, so it's just not as extended. And then the lower as well, shorten the retromolar pads, both sides. So this is the adjusted side there, taking that back. Can you see how I've really ground back those teeth there? Interestingly as well, at this review visit one, she was saying, why have you taken the plastic up to there too? I didn't want that. And she asked for it. She specifically asked for it. It's really, really difficult. I find it very difficult to reason when with someone that I've already talked about something, we've verified it, and then they've said, look, I don't want it. I didn't say that. And it's just very, very impossible. It's impossible to win an argument with a patient. That's what I find. But anyway, she accepted that. She was okay about it. Eventually I said, look, I really said, look, you really did want this. And so she just accepted it and kept it. So, because I didn't want to, I felt that drilling that away would be such a pain. So, but we trimmed it. You can see how we shortened these retromolar pads, trimmed that tooth down, really adjusted them. Quite considerable difference in look of these things there. So loads more wear. So like this, there, you can see I've really butchered these, and there's almost no contact there on these areas. So that was that. But as soon as I started to adjust these things, she became happier. It was amazing, amazing at this visit. And she walked out really happy. So these are the shapes, differences. I just like to extend things over the retromolar pads, over the tuberosities, using just get these implants supported. That's the teeth there. So that's with the new teeth in there, with them adjusted. This is the adjustment there. And then she went away. But I'll talk to you about how things worked out in a minute. But look, that's how she came in. This is a natural smile. Please look closely at her arch form there. And it's just impossible to recreate this sort of arch form like that because of the implants. Getting in the wrong just in the wrong place. And all of this heartache. And I find that treating these patients who have had existing implants done that are not great when they come to see me are really difficult patients. Are in the most difficult category of patients to satisfy. But anyway, she did come back, and at visit 3, review 3, she brought in this homemade chocolate cake, which actually was absolutely delicious. It was fantastic. So we'd actually cracked it. We really have, and done it, fortunately. So I want to look here at your questions. Um, I'm just going to have a look through your questions now quickly. So yeah, so I'm going to go through the questions quickly now here. So Octavian, Giorgio, perfect to be finished to first molars only. Do you add second molars on difficult class 2 recognitic mandible? Yes, I do, Octavian. I do use sevens as well sometimes, but if the smile needs it, but also if there's loads of space, sometimes we do. Because you've used the Gothic arch, are the teeth set up in a specific manner? Lingualized occlusion or bilateral balanced occlusion? Petros, thank you. Yes, we set them up in bilateral balanced articulation in an anatomic arrangement, but that never translates into the mouth. They'll never have balanced articulation in the mouth because the articulator, even though we've set it, it's just it's all set up nicely. It doesn't translate, but the patient will brooks it in over time. Finn, what brand opaca does Rowan use on the metal frames? Jane Mitchell, I'm sorry, I really don't know. That's something that Chris does in his lab. So Jane, I don't know about that. If you just email me directly, we can find that out. So email Chris Hesketh at Bespoke Crohn's. Noland, Nadu. I noticed that the anterior maxillary teeth were in front of the wet lip line on the lower lip. I suppose this was to overcome the implant position. If there's a lip wedging or speech impediment, what would you consider doing to overcome this? Sorry for the long-winded question. Yeah, Noland, I don't really sort of go in. I don't really understand this wet lip line. I don't get it particularly. And I don't find I have too many speech issues, but you are with my complete dentures. I really, really don't. And it wasn't a problem for this patient either. But um, uh, but I did adjust it, but not for speech issues. I love how you covered the metal and acrylic. How do you guide the amount of acrylic bulk you would add to the platal area? So it's super thin. The metal works around about 0.5 millimeter thin in thickness, but it's still quite strong and rigid. And then there's a very thin layer of acrylic. I don't know, 0.5 millimeter maybe, but I can't answer that for sure. At the very beginning, you said how Marissa was very, very talkative. How did you manage to get her to stop talking so you could do your work? That's so so Jessica's asked me a question about she's very, very talkative. I've just got to let them get it out of the system fully and before I start treating them. She came in with complaints about everything. Someone has disturbed her on the bus, baby crying on the bus. She's been to a cafe across the road. Someone's talked to her really in a bad way, and she's really cross. There's issues with the electricity bill. There's issues with everything. So she gets all of this out, but that you're going to be, I know that I'm going to be in that category where she's going to be complaining about too. And I'm thinking, should I really treat this patient or not? But in a lot of these cases, they've got nowhere else to go. So I know I can help them. I've got the ability to help them, and I've just got to do it. Jane Mitchell, I appreciate your honesty in the issues you have. I thought I was doing something wrong with having similar issues at the fitting stages. Yeah, no, they're wonky implants are terrible. Sheriff, what if, amazing presentation, thank you. What if she changed her mind and wanted different shapes of front teeth? How would you manage this? And will you charge her extra for this? Sheriff, I don't know. I think if she'd have wanted different teeth on, then it would have been a difficult conversation. Probably, truthfully, we would have just changed it and made it again and just changed the teeth on it. as in use the same fit surface, rolling strips of teeth off, does a try-in on there with new teeth, and then does it. Georgios Petropoulos, I can't comprehend the term angry. This indicates lack of trust and lack of trust, lack of respect and trust, especially after all you've done. Absolutely, Georgios. I totally get that. But some patients are just trauma survivors. I'll come to that in a minute. It's important. Thank you for sharing the story. Most important, thank you. Completed the retromolar pad extension. Was it that she was feeling them? Steve Taylor. Did she feel them? Probably yes, Steve. Great to hear from you. It's lovely. I hope you're well. And answer Annette. Wow. Thank you for this great lecture. Finlay, it's hard when you discuss things to the nth degree and they change their mind. I know. So anyway, little words of wisdom, everyone. Are benefits of hindsight here. And I find dentistry really, I love it, changing people's lives, but it's really dealing with people in this intimate setting where it's so personal. And these things are social appliances that we do. It is really stressful. And so John really, my clinical psychologist that I talk with every 3 months, I talk to him about these patients because 20% of the patients that I see in practice are really in that category of having potentially personality disorders, PDs. He calls them PDs. In these cases, he says, just give them space, give them time. And he's very, very helpful, and mindfulness really helps me with this. And then the other thing that I found really, really useful is there's a woman called Sharon Zacks based in Australia. Sharon is I think one of the only people to do who's a dentist who had done a TED talk, a massive TED talk in Sydney on treating patients who she calls them trauma survivors. And these patients have suffered something really bad in their past. It could be something to do with their teeth. It could be some form of abuse. And then that is reflected in how they are as a person. And understanding this really helps me to manage these patients too. And even though I feel the emotions are rising up in me, where I feel that they are being unreasonable and also quite accusatory towards me personally, almost like criticizing me personally, which really does make me upset. If I realize that they are coming from a dark place, something has happened, and it's not about me, it's about them, then that really helps me to do that. And she came and spoke to our Best for Study Club, which was fantastic, recently, earlier this year in London. It was terrific and really helped me. So my call to action to you guys is that I think getting good at dentures, if you're wanting to do implants and do implants, get great at positioning the teeth first so that the implants can go in the right place and be planned. I also think the simplest solution is really important. I think just doing a great denture to start off with, forget about the implants to start off with, do a really beautiful denture and see how the patient gets on with that. I think that is really, really important and overlooked in the world at the moment. So many people are wanting to just put implants in everywhere, but dentures look better than implants. Fixed restorations, they really do. And then also, I think working with an implantologist that is amenable to you guiding them, you want them to be a robot for you, so you can then help them position the implants perfectly. So my next session is next study club is going to be Thursday, June 6th at 7:30 in the morning AM for people on the other side of the planet, like in Australia, Indonesia, Malaysia, Japan, all of that area. It would be wonderful if you could join me. That's really, really fantastic. So, and thanks very much. And what I'm going to do is this whole session's been recorded and I'm going to put it onto my YouTube channel. So that's really, really good. Thank you to the 53 of you here, and it's fun. It's lovely, and I can't wait to see you, Jason, next week. Bye for now. Bye bye. Thanks. Good to see you, Yama, as well. Thank you. Bye.